You can see my screen okay, Ravina?
Yes, I can see your screen.
Good afternoon, everyone. We'll just give it a couple more minutes for a few more people to be let in before we start.
Hello, everybody.
Hi there.
Hi, Zach. I'm John Mayle. I've sent you lots of patients, but I've never actually laid eyes on you.
Nice to meet you, and you care for my family too, so thank you.
I do indeed. Yeah, love everything, and yeah, they almost a full-time job sometimes, but
I hear you.
they're delightful. And do you live in North Vancouver?
No, I'm just by VGH here.
Okay, good. Yeah. Okay.
Okay, good afternoon, everybody. My name is Anna Wallach, and I'm going to be your moderator for this afternoon's session. It's this third session of the BC ECHO for post-COVID-19 recovery. And we have, before we start, I'd like to acknowledge that my workplace is located on the traditional territories of the Coast Salish people, Squamish, Tsleil-Waututh, and the Musqueam Nations. With regards to the Zoom presentation, this is UBC CPD accredited, and we are tracking attendance by putting in your email address through the chat. So please put your full name and your email address so that we are able to monitor attendance and issue your accreditation certificates. When it comes to questions, this will be a panel discussion. And when we take questions, just use your raise hand function at the bottom of your screen. It's in the, if you look at the bottom of your screen, there's a smiley face that says reactions. If you click on the reactions, you can click the button that says raise hand. And when you raise your hand, I will keep an eye on it all and ask the questions at an appropriate time during the presentation. We have a fantastic group of panelists today, and they are all linked with providing post-COVID-19 recovery care. And I will let them introduce themselves because they are all amazing, wonderful people, and I'm scared that I'm going to miss something out by introducing them.
Well, I'll start. I'm Zachary Schwartz. I'm a general internist at Vancouver General, and have taken the lead here as one of the physicians in the clinic dealing with post-COVID-19.
And my name is Amin Nijjar. I am also one of the post-COVID recovery clinic physicians here at VGH, and I otherwise provide GIM care in the inpatient and outpatient settings here.
I'm Peter Burks. I'm a nephrologist. I also do some internal medicine. I'm the physician lead for Fraser Health for the post-COVID recovery clinics, and I do some work in the Surrey clinic as well.
I'm Rick Arsenault. I'm a general internist, and I'm the physician lead for this ECHO program. I also work at the complex chronic diseases program at BC Women's.
Great. So I think we can get started then with the presentation.
All right, I think this is me taking off here. So none of us have any disclosures or conflicts to declare for this particular presentation. Our objectives overall will be able to leverage pre-existing knowledge and resources to care for post-COVID-19 patients. And this is still ongoing, unfortunately, after a year and a half, right? This is still a novel disease to us. So we're still using data from other disease processes to better understand what we're actually doing here. We'll give you better understanding of where available tools, resources are to help the primary care physicians and other primary care providers deal with COVID-19 in their offices and understand the various presentations of post-COVID-19 and what we are seeing here locally, as well as how to potentially work them up. All right, next slide, please. So what is post-COVID-19, post-acute COVID-19 syndrome? And this is a challenge that is even bothering us. There is no standard definition for COVID-19, either with nomenclature or with definition for actually duration of symptoms. These are a lot of some of the colloquial terms that you will see, obviously, in the news or media, even in published articles. Probably what will come out of it is the PHSA, which is how NIH has defined the syndrome for a lot of the research that they're going to be undertaken. But for simplicity, we'll be calling this post-acute COVID-19 syndrome. So what is post-acute COVID-19 syndrome? You know, a lot of the literature would suggest ongoing symptoms for more than 4 weeks. When you hear in the news that, you know, 30% of the population will have symptoms. A lot of that comes down to actually using a 4-week cutoff as opposed to a 12-week. In our clinic, which is why we are seeing people at the 12-week mark, we are using 12 weeks as our kind of standard definition of what we really consider post-acute COVID-19 syndrome. The 4 to 12-week mark is still a bit ambiguous. It's not unusual for some people, even from any other bad viral illness, to have some symptoms at the 4 to 8-week mark. But we are referring that to the subacute period, as there's still a large cohort of individuals who will show significant recovery in that 4 to 12-week range, given that the first 4 weeks is a very highly inflammatory and physiologically stressful process. So for all intents and purposes, we're using 12 weeks as our cutoff here. And if you're still symptomatic at the 4 weeks, from what we know, it does not necessarily predict if you're going to have chronic symptoms or not. So the other challenge facing family physicians and even us is the inability to give a prognosis. And part of this probably comes down to that this is not a single disease. The population that we're seeing is quite different. And there's presumably not one pathophysiological process that's drawing this. I broke it down into 4 of the main phenotypes of what we're actually seeing. We're seeing our typical post-hospitalization or post-ICU syndrome. That's what PIC stands for, and that's the chronic, that could be actually some cognitive dysfunction, obviously the physical dysfunction with neuropathies, myopathies, the mental health deterioration, the anxiety, PTSD, the sexual dysfunction. This is all very well documented in the literature prior to COVID-19. We're probably the category of individuals that most people want to focus on is this non-hospitalized and very symptomatic. These are the newsworthy / media worthy patients that are popping up and what everyone obviously really worries about. And the most common symptoms being ongoing fatigue, neuropsychiatric symptoms, shortness of breath, and mental health deterioration. There's obviously an asymptomatic category, and we are seeing lots of this from our hospitalized cohort, which is interesting in itself, and trying to understand why is there a group that seems to have such a quick and rapid recovery compared to elsewhere, compared to others. And then there's the mildly symptomatic hospitalized and non-hospitalized course, which might just be a bit more of a protracted illness and a bit more of a slower rate of recovery compared to others, but often do show recovery over time. So the post-ICU syndrome, we are seeing recovery as expected, as documented in the literature for actual PICS. In this particular syndrome, we know that many are still symptomatic 3, 6, 12 months after their diagnosis, but the percentage of those who remain symptomatic as time goes on steadily actually decreases. What we are seeing locally, and what I still don't have a good grasp of, is how to predict who will fall and what kind of rate of recovery, why some people come in after an ICU stay and are back to their normal self, jogging 10 kilometers at a time at the 3-month mark, where some people cannot. And obviously that will come down to what degree of organizing pneumonia or respiratory complications amongst other physical ailments they or may not have. But what we are seeing is that for the most part, people are improving at each subsequent visit. And this is, I think, by far what we are seeing for the majority of hospitalized patients in our post-COVID recovery cohort. And as I mentioned, there is not an insignificant percentage of people who are asymptomatic at the 3-month mark, and that includes both ICU and non-ICU patients. So our non-hospitalized and very symptomatic ones are very, very challenging. And I could probably have even subdivided this further in with respect to, there's a certain phenotype of individuals who are at higher risk, let's say, and Dr. Arsenault could probably allude to this in terms of developing central sensitization type syndromes due to underlying mental health issues, prior trauma. But we are seeing a lot of people who don't necessarily have any risk factors for developing chronic illnesses like that, that have developed these types of illness. It's still a novel disease, and we don't have good estimates for long-term outcome. But what we have seen is that if you have minimal symptoms at 3 months, you're unlikely to develop any new symptoms after that. If you have a very high symptom burden at the 3 months, it's hard to predict where things are going to go. We have some people who have just remained at that degree of symptom burden over time, even at the 12-month mark. We've had some people kind of, for some reason, just improve randomly. Well, I shouldn't say randomly, but for whatever physiological process is driving their recovery at the 9-month mark. There is anecdotal evidence, nothing to write home about at this point, that vaccination has improved symptoms in a cohort of individuals, although we can't say that for certain. And the last thing that we want to say is that if you do have a high symptom burden, but you are seeing some degree of improvement on, let's say, a time scale of a month or 2, they seem to continue to improve, just at a slower rate than other people. Like I mentioned, we don't have a good way of necessarily predicting that. It's probably an estimate of 50% of positive tests will have some degree of symptoms at 12 weeks. It doesn't necessarily mean absolutely anybody's debilitated. They could have some degree of fatigue, cough, mild shortness of breath on exertion, still able to kind of partake in their actual ADLs work and schooling if they're of that age. But in terms of considering debilitating symptoms, not an insignificant amount of 20-year-olds, 1.2%, but 5% of 6-year-olds will have symptoms at the 12-week mark. And when you average that over an entire population, such as the United States, that is not an insignificant number of individuals who are in their prime schooling, prime work years of their actual life. And there have been some recent mentions in articles and an editorial in New England, thinking that this will be the next public health crisis. There are no clear guidelines how to investigate symptoms, and we fully appreciate that. And the reason for that is that there is such a wide variety of patient phenotypes. So there's not going to be a cookie cutter recipe to investigate these particular symptoms. Next slide, please. What we can suggest, and what I've been telling people, especially answering the race line, is investigate as you would if COVID wasn't actually diagnosed. And that's how I am taking an approach. That's how I'm taking an approach to many of the individuals. Look for red flags, look for pleurisy, signs of DVT or PE, signs of increased intracranial pressure that may suggest a central thrombosis, although these are all very rare in our non-hospitalized cohorts, and then hypoxia for any potential long-term complications, whether that's venous thromboembolic disease or long-term complications such as an organizing pneumonia. Mental health screening on all individuals, given this is such a prevalent symptom or issue that we are seeing, and it can either be a deterioration in previously diagnosed illness, or we're seeing a de novo anxiety, PTSD, and depression, and in many of our patients. So fatigue, do as you would for anybody else. Anecdotally, what I am seeing in my clinic is we're seeing a much higher percentage of people screen positive for sleep apnea. And for example, for people who are asymptomatic in the population, they think roughly 5% of people, if you screen them with a level 3 polysomnogram, will actually have sleep apnea, and 20% of the very symptomatic people will. There was a small cohort that was published that seems to suggest that there's a much higher incidence of sleep apnea in our COVID population. Some of the comorbidities, hypertension, obesity, are clearly risk factors, and that might be confounding things. But I've seen several individuals now who have had some viral illness that have had that we found severe sleep apnea, who were quote unquote asymptomatic prior to their actual diagnosis. And similar to any cardiac type symptoms, we're not seeing very much in terms of this myocarditis from vaccination is a separate topic, but in terms of cardiac issues related to the actual disease process, we're not seeing very much in the non-hospitalized cohorts. And if they were hospitalized, it's usually diagnosed at the time of their actual illness. But if any high-level athletes or anyone needs to get back to physical exertion, a quick screen with an ECG and even a BNP, which are now mentioned up there, is reasonable. And once again, I just wanted to re-emphasize screening for mental health. Next slide, please. Just a few pearls that we've actually noticed. Chest x-rays in non-hospitalized patients at the 12-week mark are almost completely normal. It doesn't necessarily mean there's nothing there, but what we're looking for is presumably at the microthrombus or at the microthrombi level, and they're almost always normal. But they can be useful for reassurance for certain individuals. And similar to what we're seeing for CT scans. And what I mean by here is that in our non-hospitalized cohorts, where we were actually scanning almost everybody initially, they're almost entirely normal, except for maybe incidental findings. The changes that we're seeing in our hospitalized cohort are not unexpected. We're seeing some ongoing inflammatory ground glass changes. We're seeing organized pneumonia in severe cases, but nothing that's not predictable before we actually seen someone. PFTs in our hospitalized patients might show a decrease in our DLCO or diffusion capacity, but in our non-hospitalized patients, almost nothing is actually coming up, and they're almost certainly normal. D-dimers we've been following routinely on all of our patients. Approximately 50% of hospitalized patients will have persistently positive D-dimers, and we're seeing these upwards of 9 months out. And this is probably just related to endothelial dysfunction. It's not necessarily related to venous thromboembolic disease. And then if liver enzymes are still elevated at the 3-month mark, there's probably an alternate cause like fatty liver disease, and would screen them for hepatitis serologies. Next, please. And I'm not too sure if someone else is popping in here from Pathways, but if they are, please cut me off. We do have a post-COVID-19 recovery pathway available on Pathways, going through many of the actual symptoms and various practical approaches that you can always use in your family medicine offices or other primary care offices.
I am here from Pathways, but
thank you.
I'll show you in a second though. You finish
Okay.
your thing and then I'll show the care pathway.
Thanks, Tracy. I will hand over right now. It's a good
Oh,
time.
you're going to hand it over right now? Okay.
Perfect.
So let me share my screen. And let me just, anybody on this call who does not have Pathways access, I'm putting something in the chat so that you can make sure you get your Pathways access. And so here we are on the home screen of Pathways, but if you don't have access, go to pathwaysbc.ca and hit the request access. And for those of you who do have access, I hope you, like myself and most of the docs I know, have Pathways open all day behind your EMR and use it as a reference. Up on the home page, there's a banner, and in the banner, we have included this post-COVID care pathway. So if you click on that, it takes you straight to what you were just looking at, and you can use it while you're having a visit with patients. And it includes, I'll highlight in the left margin, a bunch of resources that the PHSA post-COVID committee has approved. And you can email the resources straight to the patient from the care pathway. So there's the fatigue handout, and I'll just show you what it looks like so you have some sense of what it looks like. And if you were going to email it to the patient, you hit this email icon, and now it's going to attach to an email that's going to go from a no reply email at Pathways. So you're not opening up a two-way communication channel with the patient. It's coming from a no reply email at Pathways, but it will have your name so they can tell, you know, who sent this to them. And the recipient's email is not stored by Pathways. You ask their permission. And then if you send this, and you see it's attached, and I'll just put my email in there. And you see it's attached, the post-COVID handout that I showed you, plus the whole page of PHSA links. And if you wanted to attach a message, like here's what you requested or what we talked about or book follow-up, you can add a message. So I guess I'll say, here's the information we talked about, email to recipient. And now I get a little copy to clipboard message. And if I hit copy to clipboard and I had my EMR open, everything here highlighted in yellow that the patient provided their email and their consent to receive this information, you stick it in your EMR note. And I find it fantastic. I use this all day sending emails to patients. And here we are back again on the homepage banner. And I'll just highlight another thing that I'm using that's just come out from CDC, which is the screening tool for direct patient interactions. And it's got the questions to sort out what protective measures you should be taking in the office. And then we've pasted on as a second page, if the patient needs to go for testing, quick links to be able to email them the testing information, depending which health authority they're in. So that's there as well. And then if you're already looking in a particular specialty, I'll show you that if you go to the specialty of COVID-19, this is another way to get to that care pathway or to that screening algorithm. So the post-COVID care pathway is a nice big sexy button here up at the top of the specialty of COVID-19. And again, you open that and you're going to get that care pathway that we just looked at. And then it's got quick links to COVID immunization if you want to email the patient, the links to the immunization drop-in sites, COVID testing. You can email post-COVID recovery. It's got the provincial clinics. And then you can also go into patient info. And you'll notice we've got some new filters in COVID patient information. They're specifically post-COVID-19 recovery materials. And here, each of those individual handouts and information items that were in that care pathway, the algorithm, are also individually emailable here. And there's also the new post-COVID long haul online support groups. So that's a collection of Facebook groups and things for long haul post-COVID patients, and then physician resources and post-COVID recovery physician resources. There's the care pathway that I already showed you. there's the BMJ reference, long haul COVID in primary care and post ICU. So remember, within the specialties that you can look at physician resources or patient information. And when you hit the button for the specialty of COVID-19, it does drop you in the Community and Health Authority Services tab. But don't forget that you can go to physician resources or patient information. And also notice, I've saved some favorites in the patient information. And to save a favorite, all you need to do is click on a black heart and it turns red, and then it's one of your favorites. And then they're easier to find. You can also find all of your favorites up here. And then if I wanted to email, say, this post-COVID anxiety, face COVID, and testing center wait times, I can pick both of those and go through the same email that we saw last time and email both of those to the patient. I think I'll stop there and let you guys get back on with your presentation.
Thanks, Tracy. That's really great.
Right. Peter here, I'll take over the next few slides. Thanks, Zach and Tracy. That was excellent. So one of the next things we wanted to discuss is, of course, we do have time constraints on appointment time. So how can we support our patients with often complex symptoms and complaints in such short visits? So one thing would be to direct these patients to resources prior to the appointment. There's a lot of resources that you just saw on Pathways, on the PHSA post-COVID website, including those handouts on things like breathlessness, shortness of breath, headaches, really all of the common symptoms, as well as videos on the website for PHSA as well that the patients may find useful. So you can arm them with a lot of information prior to coming into the appointment, and that might focus things in and make the patient happy. These patients have been dealing with very difficult limiting symptoms, often for a prolonged period of time. So they can be really frustrated. Their reactions they may have gotten from family members, friends, or other people who've had COVID who didn't develop post-COVID syndrome may have been difficult as well. So validating their symptoms, telling them that, we do see this. We see a lot of patients with similar symptoms. For the most part, as Zach said, they are getting better. Normalize the symptoms, that you're not alone, and really just being there to listen, therapeutic listening, letting the patient describe to you what's going on and allow them to feel heard and validated can go a really long way. And we've gotten a lot of that feedback in our clinics as well, that, just having someone understand how they're feeling and how often terrible they may be feeling was very therapeutic. And then to get some of these resources. So there are patient-based initiatives too that can be helpful. There was the online support groups on Pathways that Tracy just discussed. There's some good work being done by Jacqueline Robinson from our ICCN group, sharing patient stories, specifically in coastal health. So keep tuned for some more of those resources that patients can find helpful as well. In our post-COVID clinics, we do a lot of the screening with our questionnaires beforehand, screening the different systems, screening for breathlessness, physical function, mental health. Having a screening tool could be helpful that could be administered prior to the visit. And then, prior to the patient coming in, you'll have a bit of an idea of areas to focus in on. And because of the time constraints of the clinic, focusing on 1 or 2 symptoms at a time may be beneficial, especially the problems that are most worrisome for the patient, such as breathlessness or their profound fatigue. Maybe you tackle one of those symptoms at the initial appointment, and then they have to have an additional appointment after they've had a chance to read through some of the resources and do some of the self-care techniques in the interim. Next slide, please. So patient expectations, people are sick of the pandemic. We're all sick of the pandemic, but I think from at least what I've heard from GP colleagues is patient expectations have often become really high more recently, and managing these expectations in the area of post-acute COVID can be a real challenge. So one of the biggest things to get across is, unfortunately, there isn't a quick fix for this. There isn't something they can come in to see you and you're going to send a test or start a treatment and everything's going to be better. We can help and people will get better, but it takes time and it takes a lot of effort and it takes a lot of active participation and commitment from the patient as well. And I think that's an important thing to get across, that they have to take on a lot of the work and responsibility of getting better, and you're there to also help them, as well as other resources that we have. So going along with that, the recovery really is rooted in self-management, and we do have self-management tools available, some of which were flashed through on Pathways there, and some are on the PHSA website. Things like pacing, symptom journals, energy envelope, and working within that. And a lot of this is sort of analogous to the world of myalgic encephalitis or post-concussion syndrome, where self-management can go a very long way. And it does empower the patient as well. Another thing, when people come into appointments and they're having such severe symptoms, they sometimes sort of hope to find something on their blood work, on something on their investigations that'll tell you, oh, this is what's causing your symptoms and this is what we can do about it. Unfortunately, for a lot of patients, especially the non-hospitalized cohort, their investigations will be non-specific or often normal. And that, just because we don't find anything wrong on these investigations doesn't mean that the symptoms aren't real. And even if we do find something on the investigations, it doesn't always necessarily change the treatment and some of the self-management techniques that I discussed above. So just being very explicit to patients about that can be important for managing their expectations. Also, people do, for the most part, get better. It can take a really long time for some patients or shorter for others. But one thing to emphasize is the recovery from this is not linear. There can be good days and bad days. I think a lot of us have seen sort of this post-exertion symptom onset that can be even days after exertion. So right direction, if there is a setback, not getting overly frustrated and actually going and expecting that may happen as you're trying to increase your activity going forward. So the good days and bad days is a very important thing to tell the patient about and for them to understand. Next slide, please. So Zach also had alluded to mental health concerns being very common in post-COVID. And I think a lot of you have probably seen that and experienced that firsthand, if not all of you with your patient populations. So how can we best support patients who are struggling with mental health concerns when resources are limited, especially during a pandemic? So I would recommend approaching these mental health symptoms or concerns in the same way you would in your day-to-day practice in non-COVID patients. Again, make sure to validate your patient's symptoms, active listening and normalization of the symptoms. There are a number of resources available, both COVID specific and non-COVID specific, online for mental health. And we will go through some of that, I believe, with Tracy in Pathways. And there's going to be also a dedicated Project Echo session coming up in December, specifically targeted towards some of the mental health concerns in post-COVID, because it is so common and can be difficult to be the practitioner in that area. Okay, next slide. So make sure that you do screen for these things because they are so common, and it's not just anxiety. It can be anxiety disorders, panic disorders, but also mood disorders and depression, substance use, which is often can be a coping mechanism as well, and PTSD, especially in the populations that were very sick or hospitalized or in the ICU. PTSD is extremely common in those populations, but can also be an issue in the non-hospitalized population. And like any patient you're screening for mental health concerns, look for some of the red flag things that may cause you to act more urgently, such as ideation for homicide, self-harm or suicide. So in terms of management, as much as possible, make sure you tackle the physical symptoms because they're likely contributing and exacerbating the mental health symptoms. Recommend the pacing strategies and use some of the documents that we've provided. This is very similar to the myalgic encephalitis, chronic fatigue, or post-concussion syndromes as well. And some of our other people on the panel are really experts in that area and can talk about that better than I can on this session. If someone is not meeting a DSM criteria, there's still things you can do, non-pharmacologic management such as mindfulness and meditation, exercise, but exercising within your energy envelope, referring for psychotherapy, cognitive behavioral therapy, and a number of digital patient resources. And there's even a lot of good applications available on smartphones. If you are meeting a DSM criteria and you meet criteria for treatment, then it would be managing as per the current guidelines, including both the pharmacologic and non-pharmacologic aspects of that. Okay, and I'll hand it over for pathways demonstration at this point. Thank you.
All right, I'll just unmute myself. And here we go. So for mental health stuff, you're going to go to the pick and pick, say, psychiatry adult. And you'll notice again that you get dropped into the community and health authority services tab. And every division has highlighted up at the top the services that would be frequently needed. So things like the bounce back program, things like the Compass mental health navigation, Foundry is a common frequently needed. And the CBT skills group that started with the Vancouver division, that's an online CBT skills that's great for post-COVID recovery and lots of other things as well. Maybe I'll just click into that program and show you the additional detail. And then it's got links for a patient to read more about the program or for you to refer a patient. And you can email that item to a patient to review all of that. And so those are some of the commonly used active interpersonal. Somebody's actually doing something for someone. So bounce back and the online CBT skills group, those are two that are online interactive. Somebody's actually doing something for someone type of thing. And you can use the filters as well to filter for specific kinds of programs. And you get a shorter list, anxiety adult. And here now we've got the two short, bounce back and CBT online being two of the most commonly needed services. If you're looking for helplines or crisis lines, and you were looking specifically for helpline or crisis line for youth, you get again a shorter list. And remember to use the tabs. So for physician resources, if you're looking quickly for those scale and scoring tools, and specifically say you're looking for anxiety scale and scoring, you're going to get your GAD-7. If you're looking specifically, I didn't even know there was this scoring tool called the McLean score for borderline personality disorder, but that's a helpful one. And then specific eating disorders, scale and scoring tools. I think the medication physician tools are also pretty useful. There's the QT interval, having a calculator to check the QT intervals, switching antidepressants and antidepressant medication overview. So that's the physician resources. And then in patient information, so there's two basic categories of patient information things. There was the stuff in the community and health authority services where it's not just information, but somebody is actually going to do something. It's interactive, like those online CBT or bounce back. And then there's just static informational items. So if we filter specifically for anxiety, it's still a pretty long list of anxiety type of stuff. It kind of anxiety provoking how many supports there are for anxiety. Anyway, you need to take a little time and decide which things you think are most useful. But I often send people this 1-minute guided bubble breathing. And then Kelty's Key has a whole bunch of online modules that people who don't want to actually go on Zoom with someone else or talk to another person on the phone, that they can work through. And they have a nice CBT online module. Then there's the Anxiety Canada website. So if you go through and look at some of these, and there's the Nature RX as well, which goes through the benefits of not just taking a walk, but taking a walk in the forest. Take a little time, set yourself aside, maybe 10 minutes every day to just look at the different anxiety materials using the CBIS approach of chunking the task for yourself so you don't get so anxious in dealing with anxiety patients. It's once you've picked a collection of things you're comfortable sending, it's great. And then I always put that pasted note at the bottom of my EMR note and tell patients, I'm going to ask you next time what you thought of those different resources I sent you. And I want you to tell me which ones you thought were stupid and useless and which ones you thought were useful. And I'm starting to learn which ones people find the most useful. And that 1 minute breathing thing, I have yet to find anybody who didn't find that somewhat helpful as just a quick thing. And then some of them really liked the online modules, others didn't. But so poke around, like I say, you'll be landed when you select psychiatry adult, you'll be landed in the Community and Health Authority services where it's a live interactive service. But don't forget there's physician resources and patient information within psychiatry that can be useful at point of care. There you go.
Thanks, Tracy. And so, yeah, a lot of good resources there on pathways. Probably more almost than you need on that one site. So finding your favorite ones would be beneficial. But this is another, as we were going.
That's the one I was referring to. The Victoria-based CBT skills group is the one that has the frequently needed service. It's online CBT. Yeah.
Okay, excellent. Yeah, we were actually in touch with them as we were rolling out our post-COVID clinics as a resource for the patients with sort of mild to moderate anxiety and post-COVID mental health issues. Sounds like a very good resource, developed by psychiatrists, but led by other physicians as well. 8 weeks can be done virtually. So that's a good option. And I'm not going to go through all of these, but there's a number of other online tools that can be used, including Calm, like videos for meditation, and other websites that have help for patients that are struggling.
And I'll just point out all of those are on Pathways, and there's a brand new support groups that lists those three online support groups. If you just type in COVID long haul support in the search, you'll find a one pager that has those 3 long haul supports. And then each of those, Here to Help, Foundry, Calm, Anxiety Canada, they're all in Pathways as emailable individual items.
Excellent. And, challenge number 7, we may have sort of dug into quite a bit now, so there's not too much to add, but just to highlight on the next slide that there's a lot of COVID specific resources, but the chronic fatigue and insomnia, brain fog, and cognitive dysfunction, and many of the other symptoms experienced by patients with post-COVID are not necessarily COVID specific. They could be other post-viral syndromes or related to some of the overlapping syndromes we discussed earlier. And there's a wealth of resources out there for you to access. Some of these being, Pathways, we highlighted the PHSA website. The concussion guide is excellent as well. And, really many different resources. So you also can get help reaching out through the race line when needed, and through eCase, which one of the post-COVID physicians is manning each week.
Okay. I think I'll take over from here. Thanks, Peter. My name is Amin Nijar, and I will go through these fairly quickly so we have some time for questions. I think you guys are probably getting a sense that there's these similar themes. I think key is validation, self-management, and then rest is what I'll come to at the end. And I think so many of you guys are already doing this so expertly with your patients. So for those patients who have not had a positive COVID test, there's been a lot. I've had, not so much now, but 6 months ago, 9 months ago, that people really needed that validation that their symptoms were real and that it was due to COVID. And I think, again, the key is just validation here, that they are having real symptoms, and then also understanding that they can have symptoms from another infectious illness. We know that is well established, and just because they could have still had COVID and maybe their serology is not positive later in their illness, or it may have been some other viral illness, which we know can present with very similar symptoms. And again, the same type of self-management approaches apply here, which you've seen a multitude of those resources during this talk. Next slide. In terms of for your own reference, like when should you refer patients to see us at the clinic? Next slide. So if you're hospitalized and you're concerned about end organ damage, you know, we're not seeing too much of this. Mostly this has been around people who had organizing pneumonia and are still having significant dyspnea. Their diffusion capacity is decreased. Those are kind of the ones that we often do follow up long-term in conjunction with respirology. Certainly if they are having to present multiple times and need some more specialized care, or there's new evidence of end organ impairment. And then really is that key 12 weeks if they're continuing to deteriorate and they have unexplained persistent symptoms, we're happy to see them. In terms of our clinic criteria, now we are doing a positive swab unless they did not have access during that time when we were not testing everybody. If the patient was hospitalized, you can send the referral earlier and then we'll see them after the 12-week time period. And if they were in the outpatient cohort, we'll see them once the 12 weeks have passed. And again, this gets back to what Zach was saying earlier, that in general, people are showing continued improvement. And even though they may still be quite symptomatic or suffering at 4 weeks, they might continue to go along that trajectory by the time they get to 12 weeks. And you can see the triage phone number for the referral listed there in the slide. And then in terms of what guidance, you know, that's what patients are coming for. Like, what can I do? What can I do to get back to what I was like before? How do I get back to what I was doing? And really, as frustrating as it is to hear, it's rest. It's rest. And then again, going back to that self-management strategies, focusing on the energy envelope and pacing, and saying that if they are showing some improvement, that our hope is that will continue, but it will be very slow and it'll probably be too slow for what they expect. And then it gets back to managing those expectations. I know I've kind of given them like some visuals for some patients is helpful, like just to show them this is what you should be doing. Do not overexert yourself. If you're finding you're doing something, even if it is 15 minutes of walking and you get fatigued, that's too much. You have to step back. There's been great resources from the Complex Chronic Disease Program. And then also Dr. Calder, who's also on the panel, has developed other resources that I've used a lot more. Next slide. Some of these tool trackers, those are really specific and have this great list of trying to assign some numbers to what is something where a value of 10 versus a value of 1. That's also been tough to convince patients because they're really focused on their physical exertion. And I think just recognizing that cognitive loads can bring on symptoms, emotional stress can bring on symptoms. And when I bring this up, they're like, yeah. And I think putting it on paper, again, makes it real for them and is also an incredibly validating process. These tools are on our on the PHSA website. And again, I've just been handing them out or emailing them to people to start that process of logging, because sometimes when we talk about self-managing and figuring out your energy envelope, you know, they kind of get lost with all those resources, as I do. So giving them something really specific and maybe even pointing out some numbers can be helpful.
Yeah, well, that was a lot of information packed in an hour. Thank you very much to the panel. Are there any questions? We can take about 5 to 10 minutes for questions. I don't know if we're all just overwhelmed or if everything was covered. So for those who, like I said, there was a lot of information. Oh, here you go. Dr. Wang has a question. What are the pathophysiological basis for the various symptoms? I don't know that we have time to cover that in 5 to 10 minutes.
I can jump in here quickly. Nothing has been proven. The NIH has invested a ton of money, about $1.5 billion to look into this over the next couple of years. But I think right now what's ended up happening is, you know, obviously things are being inundated with acute care. Lots of theories have been thrown out, whether it's, you know, persistent viral shedding in immune privileged sites that could lead to persistent symptoms, other immune activation. This is what is, or inappropriate immune activation. This is why they're theorizing that some individuals have received benefit from vaccination in terms of overcoming that degree of kind of persistent viral illness. Not meaning that they're actually still shedding virus in terms of infectious, but in terms of having some viral particles that are still stimulating an immune response. So there's lots of theories out there. There's lots of cytokine theories with respect to, you know, when we used to use interferon for treating hepatitis C, lots of people developing very similar symptoms in terms of cytokine pathways. So there's lots of theories out there. It's not going to be one pathophysiological mechanism, but I'm assuming over the next couple of years we'll have a much better answer for this, and even a lot of our other central sensitization syndromes as they look into viral illnesses a bit more.
So there's another question, whether there's any benefit in following serum antibody levels. I know I have a lot of questions from patients asking me to test it for them.
Excuse me. No one else is going to answer. I'll go ahead. We're finding no clinical benefit for measuring antibody levels, especially in the area of vaccination. You know, obviously the Moderna and Pfizer vaccinations will be spike proteins, but it's still unclear what Johnson & Johnson or AstraZeneca will do in terms of serological levels. So it's a bit unclear. We're not finding them clinically useful at all, so I'm not recommending it, especially as there is a $75 price tag to it. And positive or negative levels are not affecting our decision making, so we're not advising in terms of pursuing monitoring antibody levels or using it as it as a titer for monitoring over time.
And there's a question asking about if there is any place for medications in the treatment of long haul COVID.
I can dive in if no one else is up for that. You treat what you have as their presentation as if they don't have COVID. So if they're anxious, you treat anxiety. If they're having insomnia, you get them sleeping. If they're having problems with attention and concentration, there is some support for using a neurostimulant, but very judiciously. Just very low level common sense. I find that if they're hypersensitive or central sensitized individuals, it doesn't take much of a dose to do any of the above. So little old lady dose for insomnia, little old lady dose for mood regulation. Just be careful that you don't overshoot.
There's a question on, do we know what the prevalence in BC is like for persistent symptoms, specifically in the under 18s or even in the under 12s?
Again, if nobody's diving in, we don't have any data for under 12s. That's very good. The 12 to 18s, I'm sort of seeing them on an ad hoc basis, and they do seem to be sort of drifting to a more adult presentation by the time they hit their 16s and plus. There, as a gal that I saw just yesterday, actually, she's a 16-year-old high-performing athlete at high school. And it was interesting because that tool that was flashed up there, the one that I helped to develop, proved to be very, very helpful. The type A parent with the type A basketball star in my office about all her symptoms being COVID related. I was able to identify with the data that they'd collected for about a month and back to a repeat appointment. They said, your system doesn't work. Her physical activity, we kept track of it, and it bears no resemblance to her rebound symptoms. So what are we supposed to do? Nothing. We rest all the time. She's not going to get better. If she deconditions, she'll never be a performing athlete again. So I took a look at the data and I saw some spikes of going up to 9 out of 10 on her symptom scale for fatigue and going back to bed after school started. And I said, what happened this Saturday? And she said, well, all that happened Saturday is she played a game of tennis with a friend. It was just a beat around game. It was nothing to get excited about. And I said, oh, okay, nothing else happened. Well, actually, we weren't even around. She did this on her own because we took her older sister back to college and she was home alone for Saturday, Sunday. And I looked at the face of the teenager next to her mom telling me that nothing else had gone on other than just taking the sister back to college. And I said, oh, how did that make you feel? Do you have an anxiety disorder? Where did you sleep? Well, I actually slept in my mom and dad's bed with the dog and I was petrified. And so 2 days later, she went up from 3s and 4s on her scale to 9s based on anxiety disorder, not yet diagnosed, high-performing athlete, very self-critical, etc. So I think that cognitive category is underestimated as triggers. And I'm learning how to do that in those teens and athletes. They are really interesting psychology to get COVID.
I can't speak specifically to BC because we don't denominator, right? We have a bit of a referral bias in our actually clinic, but the UK are well ahead of us in terms of actual research, and they have self-monitoring apps followed actually about 3 million people in the UK over time, and they're thinking probably about 5% of people will have ongoing symptoms after 12 weeks, at least the ones that are self-reporting. And interestingly, they just published in Lancet that it turns out to be about half of that if they've actually been vaccinated. So there actually is some potential evidence that vaccination will decrease the incidence of post-acute COVID-19 syndrome.
Okay, I think that's unfortunately all the time we have left for questions. I know there are a couple left over that we aren't able to get to. Just a reminder that this presentation and all the links that are noted on the slides are going to be posted on the PHSA website. If you're like me, you're absolutely overwhelmed by all the information. And again, a reminder that everything as well on Pathways is right at your fingertips. And it also will answer some of the other questions that were asked today about the drug therapies evidence review is also in the physician resources in Pathways. There was a question about the clinics, and the clinics are multidisciplinary. They get PT, OT, nursing, social work. So that's a great step for our patients. If you have not logged in your attendance in the Zoom chat, just quickly put your name and your email address so we can make sure that your accreditation certificate gets to you. You will also be getting an evaluation form. Please fill that out. We determine our subsequent topics based on that. And in fact, our next session on October 12, again between 12 and 1, is based on the comments that we collected, and it is going to be on post-COVID-19 neurological symptoms and rehabilitation, and the presentation is going to be from Dr. Jennifer Yao from GF Strong. So we hope to see everybody there. Thank you to our wonderful panel today for your presentation. And like I said, I hope to see you all in October, and have a great rest of your day.